So we have, welcome back from the break. I hope that there was some good networking that happened. We have a little bit of a different format to this next panel to mix it up a little bit. And the way that we're going to structure it is that we have two great panelists who I will introduce in just a moment. They're going to each give their comments through their lens, through their perspective that are complementary. And then I'm going to take about 10 minutes to ask them some moderated questions that they can answer. And then we're going to open it up to all of you. So I just wanted you guys to know how we're structuring this next panel. So our panelists for today, welcome to both of you, are Michael Currie and Dr. Ali Shirvani-Mahdavi. So I'm going to start with you, Mike, and I'm going to introduce you since he's our first speaker. Mike is the Senior Vice President and Chief Health Equity Officer at UnitedHealthGroup, and he has focused his efforts on health equity at UnitedHealthGroup since 2010, and he has truly dedicated his entire career to advancing public health equity and well-being. He serves on a full range of boards and committees that are focused on addressing barriers to health care. You can read about all of them in his bio, but there's one that's relatively new that didn't make it to his bio, and in March he was appointed to the board of directors of CHC, which stands for Creating Healthier Communities, so congratulations on that, Mike. Dr. Ali Shirvani-Mahdavi was until very recently the Vice President of Analytics at Optum, focusing also on health equity and social determinants of health. 20 years of experience in healthcare and analytics consulting, really extensive and diverse background in healthcare analytics, health equity, quality management, consumer behavior. Ali received his PhD in behavioral economics and master's in systems engineering from MIT, and it was recently announced that he'll be returning to his alma mater as a faculty member. So big congratulations to that, and thank you for agreeing to join us for this session, even though you're going through that transition. So with that, Mike, I'm going to give the floor over to you and take it from there.
That would be helpful, wouldn't it? Good morning, everyone. Good morning, everyone. Very good, thank you. I want to spend a little bit of time just doing some level setting. And then after we do the level setting, obviously I'm going to pass it over to my colleague for him to share some information. But I want you to have this baseline information in preparation for the Q&A that we're going to have. And then hopefully it will give you some thoughts and ideas about questions that you may want to ask of us when we get to that portion. First thing I want to do is level set you on UnitedHealthGroup. UnitedHealthGroup is the mothership. UnitedHealthGroup is really two entities or two organizations, UnitedHealthcare and Optum. What's the difference between the two? UnitedHealth, very simply, UnitedHealthcare is the benefits administration portion of the company. That's where you get your insurance card, your network of providers, your call center. It's all things associated with health insurance and benefits administration. Optum is what we consider the health services side of the organization. That's where we do a lot of analytics, we do a lot of care management and support. That's where our pharmacy benefit management is, a whole host of other benefit services type functions and activities. And you see on the my right side a lot of the things associated with what we are. We're guided by our values, where we have a host of data, so we're powered by data and capabilities. You see our strategic growth areas and so on and so forth. The big takeaway I want you to have is that UnitedHealthGroup is the corporate entity. And under the corporate entity is UnitedHealthcare and Optum, and we all play seamlessly together under the big umbrella of UnitedHealthGroup. Now, here's where it's important to level set on understanding, both terminology and understanding. So what is health equity? And here's how I explain this to audiences. I want you to think about health equity as the tip of the iceberg, the top of the mountain. It's the ultimate goal. Health equity is a goal. It's the ultimate goal we want to achieve at some point, hopefully in Mike Currie's lifetime, where everyone who accesses the healthcare system has is navigating through health, has the opportunity for optimal health status with care and support that is specific to their unique needs, not just what's on the shelf or not just what organization offers, but care and support that is tailored and specific to their needs. That is achieving health equity, is an aspirational goal. That aspirational goal is impacted by health inequities. Those health inequities commonly show up as social determinants of health, all the things that I'm sure this audience, transportation issues, food deserts, poverty, all things associated with societal, social, and individual risks or social determinants of health. Those are the health inequities. And those health inequities manifest themselves as health disparities. Disparities, it's the data, it's the increase in mortality associated with this, decrease access to a certain service related to that. It's the data. It shows up as the data. It's important to understand that. So as conversation happens, when you hear terminology like cultural competency, diversity, equity, and inclusion, health equity, health disparities, those terms are not synonymous. They have different meanings and different purpose. So that's why I lay out health equity aspirational goal, health equity impacted by health inequities. Inequities show up and are observed as health disparities. At United, we have this ongoing almost 2 decades of commitment associated with this work. As we all know, all things associated with 2020 and all of the unfortunate realities associated with 2020, COVID, killing of George Floyd, civil unrest, election unrest, you add up everything associated with all things 2020 and a couple of years after, there was a significant understanding or an increased understanding and appreciation for all things associated with social risk factors and health disparities. I mention that to you because we've been doing this work since 2010, long before it was common language and commonly discussed in many different meetings. So we've been at this work for a while. And as you can see from the slide, it's an opportunity for us to really live out our mission to help people live healthier lives and help the health system work better for everyone, because it's associated with improving access, affordability, experiences, and healthcare outcomes for not only all the members that we touch, the close to 100 or so million members that we touch, but for all individuals that access the healthcare system. And it all starts with, and I'm getting ready to turn it over to my colleague here, who understands and appreciates this very well. It all starts with being able to understand where disparities exist in the first place. I'm going to call it the 4 blockers, the 4 blockers. We leverage our data to understand what health disparities exist. That's associated with the measure, the health measure, or condition. What health disparities exist, where they exist, meaning geographically, state, county, region, where they exist, what population or populations are most impacted by race, by gender, by age, by disability status, population specificity, and then last but not least, the 4th is the order of magnitude of the disparity. The order of magnitude allows you to prioritize, because when you evaluate and assess for disparities, you will find disparities pretty much everywhere. And there has to be a process of prioritization to understand where to start, where to go, how many resources and how much resource you put into it, and so on and so forth. And as I get ready to close out, I use this slide quite often to help everyone understand why we focus on health equity versus health equality. And just assume that you need a bicycle to go from health status point A to improved health status point B. Under the framework of equality, everyone will get the same size bike, same brand bike, same speed bike. But we know individuals are of differing abilities, ages, sizes, genders. That's where a focus on health equity comes in, because it focuses on the unique and specific needs of individuals. And here's where I close out. In doing this work, I want you to think about a health equity mosaic or the health equity puzzle. And in that health equity puzzle are the big puzzle pieces associated with doing this work in the most meaningful and sustainable way. Obviously, you can't do this work without evaluating and assessing for health disparities. So that's the health disparities analytics. Big puzzle piece. But there's also that work associated with understanding and being able to address the social determinants of health because of the significant impact they have on one's ability to access care and achieve optimal health. So there's work that is associated with SDOH. There's diversity, equity, and inclusion work that brings a diversity of thought into the work that we're able to do. There's a lens of health literacy so that we're listening and communicating with those that we serve in the most appropriate way. There's cultural competency and implicit bias training so that there's a baseline of understanding of all the individuals that are doing this work on how to listen and respond, terminology, and all those things associated with us doing our best work to serve those that we serve. Supplier diversity so that all the vendors that we work with have a type of ethos and lens associated with this work that is aligned with ours. There's obviously research and development. You never want to stand still. So there's continuous R&D work and analysis that goes into doing this best work. And last but not least, we recognize we can't do this work by ourselves. It's impossible. As large as UnitedHealthGroup is, we can't do it by ourselves. It requires partners. And that's where we leverage our lens of social responsibility to be able to support partners in doing this work to advance health equity across the country and, for that matter, across the world, because we not only see this as an opportunity to do this work, we see it as an obligation as well. So with that, I thank you for listening. I hope you learned something, and I'm looking forward to our Q&A.
Thank you, Mike.
It's on.
It's on. So thank you, Mike. I do not have a presentation, so I'm doing this naked, so bear with me. And I, as mentioned, I recently left Optum as the lead for health equity analytics to join as a principal at Charters Consulting, as well as my alma mater at MIT as a faculty member. And what I want to emphasize a few things that I have heard during this conference. One is the importance of obviously data and analytics and understanding the individual and the importance of social determinants of health. One of the big areas that we focused on when I was at Optum, and I think it should be a focus of everyone, is that people are actually not social. I mean, you don't go to the doctor with your neighbors. You go to the doctor by yourself. Your determinants of health are very unique to you. Yes, it's true that your zip code is more important than your genetic code in determining your outcome and your quality of care and how you end up. But at the end of the day, you go to the doctor by yourself. And the barriers and the motivators that you have that prevent you to go to the doctor for your outcome, for the quality of care you get, are yours. And the social community, the people who are supporting you, the care that you're receiving are all yours uniquely. And I think that is what we were trying to do, and what we did at Optum was this idea of person-level understanding of social determinants of health. What does somebody's social isolation look like? What does somebody's financial security look like? What does somebody's transportation security look like? Et cetera, et cetera, et cetera. And how does that translate to disease progression? How does that translate to substance use disorder? How does that translate into whether you get care management that you qualify for and you have the access to, but you don't use because of health literacy issues, because of cultural reasons, because of financial reasons, because of a whole bunch of reasons. That is, I think, should be the goal of everything we do around health equity, is to get as close to that individual's personal needs as possible. And it's not easy, right? You have privacy issues, you have data issues, you have analytic issues, you have data, like clinical issues. You have to connect all these dots together. But I think we're getting there. I think we have a lot of, between AI, between the modeling work that we're doing at Optum and elsewhere, in terms of really connecting the social to the clinical to the healthcare, and really understanding how one thing leads to another thing. And I know the topic of this conversation, this panel, was on global health equity also, so I want to address that a little bit. I live in Minneapolis, I live in Uptown, and in my zip code, and again, when you look at like social vulnerability index that CDC puts together, it's at the census block. On one end of the block, you have $2 million homes. On the other end of the block, you have Section 8 housing. If you looked at SVI, it would look average. It would look like, it's kind of vulnerable, but, it's hard to tell. If you ask the person at one end of the block how vulnerable they were versus the other end, it would be giving you a completely different answer. And not just because of financial reasons, but because of how they view their cultural backgrounds, the way they understand the health system, the way they understand the culture and how it works here. And it's very global in nature, right? Again, 55408, you have, Somalians, you have, Hmong population, you have all sorts of different ethnic backgrounds who have very different understanding of how this culture works and how they can interact with the healthcare system. And I think, again, the closer we can get the data to the person, the better we are. The closer we can get the social to the healthcare data, the better we are. But also, the more importantly, if you understand that geographical, again, zip codes matter, but persons matter more. And I also want to talk a little bit about just the global nature of health equity. In the sense, when I was at MIT and will be at MIT, we did a project around the relationship between technology, environment, and health. And we worked in China a lot. And one of the things we realized significantly during that research project was that environment is really a big issue when it comes to health also. So when we thinking about health, and when you're talking about zip codes, when you're talking about individuals, where they live also matters in terms of the environment that they live in. What kind of housing do they have? What kind of transportation do they have? What kind of pollution do they engage in? Are they suffering through? And I wanted to bring that up because of, again, the topic of this conversation around global health equity. And then finally, I think it's the fact that in the United States, we really do live in a very global community, right? I mean, people who use healthcare here come from so many different backgrounds, so many different understandings of health, so many different ways of experiencing healthcare that we are really thinking about health equity in a global way when we are thinking about it in the United States. And it's important to acknowledge that, not only from a SDOH perspective, but also from, again, a personal perspective. And on that note, I'm going to pause because I think we are on cue.
If I could very quickly.
Please.
In 30 seconds, you made a great point that I'll put a fine point on, especially for the students in the room. So we talked about this difference between zip code and genetic code, so space and place. Genetic code allows those of us in the healthcare system to determine the most effective treatment modalities. Zip code or space and place influences and impacts the access that you have to the healthcare system and your overall healthcare, your overall navigation of the healthcare system. That's the differentiation between the two. Effective treatment modalities versus how you access and navigate.
Mike and Ali, thank you so much. Mike, I would consider myself a pretty sophisticated consumer, an educated healthcare professional. That was the best description of health equity, inequities, and disparities I've ever heard. And I really, really appreciate it. Thank you so much. It was really excellent. I saw everybody taking notes. So, when you think about, I was also struck by your definition of health equity versus health equality. And you did explain it, but how does that distinction play out when you're designing programs? And we talk so much about health equity, and in order to scale, you have to think about things at some level of population or community basis. But healthcare is personal. And so how do you scale that concept of equality?
Of equity,
It's
yes.
hard. Well, equity, yeah, I'm sorry.
That's
yes.
quite all right. With first and foremost intentionality, there has to be very specific intentionality in design, and even before design, the analysis. So I go back to what I called earlier that four blocker, because once you understand both at a population level and then from that population at a more individual level, what exists, where it exists, what the cultural nuance of the population is, and then kind of how big it is, what the order of magnitude is, then we can get reasonably intelligent on the types of programs, services, interventions, initiatives, pilots, whatever it is we're going to call them, that we're going to design with that specific population of individuals in mind, to give that individual and us the greatest opportunity for a better or the best health outcome. What we're trying to get at when we appreciate health equity in the most significant of ways is we're trying to appreciate what the cultural norm, you mentioned culture, what that cultural norm is that is influencing your healthcare behaviors or lack thereof, so that we can tap into that and influence behavior change that will then influence health outcomes. This is not, obviously it's not easy work. If it was easy, it would have been done a long time ago. And especially when you think about the business aspect of this work, it takes time to get this done. This doesn't happen in a quarter or 2 quarters or 3 quarterly cycles. It could take 24 months, 36, 48 months, 6 years. There's a window of time for behavior change to happen and for us to be able to tap in to individuals in the most personal way that we can, the most appropriate and personal way that we can to drive a different type of health outcome.
Thank you. Ali, feel free to comment, or else I have a question for you.
Yeah, I would add to it. You know, I think Mike, you mentioned this. For this to work, it takes time. It's important to realize, you know, we are in a, you know, private healthcare system, right? Despite the fact that it's paid mostly by the government, the incentives need to work, right? We need to kind of align. You know, we were talking about the providers earlier and the health systems and the health plans and Optum and everybody else, but I think and the community and CBOs. I think we need to kind of figure out not only how we leverage the social services that are available, and again, it was brought up, there's like 800,000 CBOs out there, but how do they get paid for it? How do we align those services? How do we connect them to the people who need it for the right reasons at the right place at the right time? And again, it could take 4 years, it could take 6 years, but unless we figure that out, we're gonna have a hard time getting there.
Exactly. So Ali, you, in a previous talk that you gave, you emphasized that data alone is not going to solve the health ecosystem's problems, and that we need collaboration and connectivity, interconnectedness, which is what we're all about. So where do you see the lowest hanging fruit? Is there anything that people in this room can be thinking about that is achievable, not less aspirational, more achievable?
I think it's focusing on the highest need areas for the populations who are most vulnerable. And that seems like a loaded statement. But like the work we did, at Optum's Center for Health Equity, right? We had this grant from Optum, United Health, to do anything we wanted to, right? Here's $1 million, go do it. And we literally sat there going, oh my God, $1 million, it's a lot of money, but is it really a lot of money? What are we going to do with this? And what we realized is that there are ways to really help very specific populations with very specific vulnerabilities for and this is the important piece, very good outcomes. So we focused on Ward 7, Washington, D.C., maternal health. Very focused, and we worked with the community resources, CBOs, health systems, and this is a population who is very vulnerable, let's put it that way. We even focused on like the third trimester moms or birthing parents who had housing security issues. So I think from the low-hanging fruit perspective, if you try, as a terrible consulting term goes, boil the ocean, it'll fail. It will fail completely. But I think there are very specific scenarios where the outcomes are easily determined by the level of support you can give them in social and medical way.
As you described that, you got excited about it. Is that the accomplishment that you're most proud of?
Oh, I am extremely
I love
proud
it.
of that.
I just love that.
I mean, honest God, yeah, it glows me.
That's awesome.
Yeah.
Mike, would you, can you pick another one that just makes you glow, that you tell your family about?
Yeah, it's the opportunity to leverage a different payment model to drive everything that we continue to talk about. And the greatest opportunity, at least that exists now, maybe something different will exist in another 12 months or 24 months. But the whole notion of value-based care really is rooted in being able to best drive health outcomes by focusing on the whole person, not just the sickness or illness or condition that walks in the room. And in order to best address whatever that sickness is, you're looking at the whole person, their social risk factors and all things associated with it to drive a better outcome, and then providing payment incentive to do that. That I am super excited about. There's some pilots going on in United now where we're testing and learning what kind of impact this has. That's the one I have my eye on and get the most wide-eyed about right now.
That's awesome. I'm going to go back, though. I'm going to press that a little bit more, because what I think we all loved about Ali's answer was that they did that in Ward 7 in DC, and you have outcomes, and you accomplished it. And that gives us all hope. And you're looking forward to incentives being aligned. So I'm going to give you the opportunity, if you would, to share with us something that you have accomplished that you are already excited about. Because I think we need to hear that this isn't something we can only look forward to in the future. We can do it now. And I'm wondering if you'd be able to share something.
Absolutely. So we have been developing for a few years a pretty fulsome strategy on being able to identify these social risk factors that exist, addressing those social risk factors as they are identified, and having an infrastructure and strategy very specifically built for that to best support our members. That didn't exist 3-4 years ago. A lot of resources associated with that. As you know, a lot of data that goes into developing the engine or the system to be able to aggregate the data, work with our partners to identify solutions, to address, do the follow-up associated with it, And now the next iteration of, because yes, the model is reactive as it exists now. As we find out, then we kick into gear. The next iteration is how we proactively identify leveraging AI, artificial intelligence and machine learning, to proactively get a read on what is coming down the pike, what kind of social risk factor is going to fire off as a bad outcome for individuals so that we can intervene earlier upstream.
I'm going to ask one last question before we transition to all of you, because it's something that I have dedicated my career to, and that's health communication, health literacy. You had it on one of your slides. We heard about it earlier from Dave. And Dave, you were talking about it with respect to health literacy among providers, administrators, researchers. You didn't have patients on that slide, and I wanted to ask you about that, but we'll do that another time. But could you talk about how you are addressing health literacy? And I'm just going to take the opportunity, since I have the floor, to say that we focus so much on individuals that are 30, 40, 50, 60 and up, who already have chronic illness disease and so many inequities that are dealing with disparities. And we aren't focusing on children and teaching them how to be health literate. And I'm just wondering whether you're doing anything in that arena or how you are addressing it.
That's a great teaser, because
that was not a setup either.
That wasn't a setup. We didn't even plan for that.
No.
So yes, in discussion right now, there is work that we already do around health literacy with, for those that don't know, there's our Just Plain Clear asset that anyone can access. And it's used for, to ensure that the words you're using are the most health literate words, hence the name Just Plain Clear. There is also a process that we go through for any communication that's going out of the organization to make sure that the words are right, but also it's at the appropriate grade level. So that's just kind of standard practice. The next evolution is being able to outreach and engage with individuals with a lens of driving better health literacy and education, information, and healthcare navigation with them in a meaningful way. That's a different type of outreach and engagement with the members that we serve. And in addition to that, there is discussion, not a pilot, at least as of today, but there is discussion about how I just talked a moment ago about going further upstream, how we move further upstream to maybe high school or college age individuals to provide some sort of a healthcare experience for them, leveraging the college experience that teaches them at the college level about health literacy, healthcare navigation, and being better healthcare consumers as they age. It's in development.
Can I add just one thing to that?
Of course.
I just wanted to mention, I think health literacy is huge, education level, all that. I think very much connected to health literacy is the issue of trust. And I think the issue of trust gets into, does the person who's giving me care look like me? Does the person who is giving me care have the understanding of where I am coming from and what are my proclivities, so to speak? And I think trust is an issue that needs to be addressed in a lot of different ways, and health literacy is one of those. Yeah.
Thank you. Mike, I want to talk to you about that after this. What questions do we have from the audience? Right here.
Amazing presentation. I did not pay you to ask that question, but I'm a pediatrician, and when you asked that question, I was like, thank you for asking that, really. And I will share, as a pediatrician who is on ground and talking to these families, these teenagers, these kids, what I feel my biggest challenge is, and thanks for using that word trust. When I'm talking to a teenager and I'm telling them that, okay, these are the things we need to work on together, there is so much disconnection from the parents sometimes. I mean, the kid is ready to listen to me, but the parents are not. I mean, and even the issues, like the basic things about eating, you know, parents like, no, what are you telling me? We don't do that. We don't buy fruits and vegetables. You know, they are so expensive, I can do that. And you're like, again, I don't want to be judgmental, but I think you can. It's just the intention needs to be there, you know. And Cultural barrier, yes. Being an immigrant, I think I understand, and then I feel that hopefully my patients understand that I do understand them, that I can make that connection. And still, so much work needs to be done. And we have data, we know the disparities, we know how health outcomes are so different, and from minority to the other population. Any hints, any tricks, as a person, as a pediatrician, how can I bridge those gaps? I just feel, yeah, frustrated, to be honest.
I'm a fake doctor, so I'll pretend like I mean, I think the big thing, and you mentioned this, that there is not only the trust issues between kids and doctors, but also parents and doctors, right? Especially for first-generation immigrants, right? The parents have a very different understanding of healthcare or even health than their kids do, who were born here and have a very different kind of life. I think my suggestion would be to work with the person who's getting care, right? I mean, just like, I mean, that should be, it should be about the child or the teenager or whoever, and bring the parents along, because they're going to be much harder to bring along than the kids by far. And I know I'm an immigrant. Yeah, I mean, you have a much better time with the kids than you would have with the parents.
Next question. You get to choose. Right here in the front.
So I think we all are aware that as we're working to help people live healthier lives, there's also a profitability that has to be maintained. I'm wondering if you have had any success using data to extrapolate out the benefits of these community-based initiatives into maybe quality of life metrics or even employment increases within a community. How do you use data to paint a picture of why this is good for everyone long term?
Yeah, so none of the evaluation to date is looked out to quality of life. What we're looking at are improved health outcomes that we would measure either through HEDIS measure ratings, star ratings associated with improvement in outcomes, cost efficiency, but nothing that takes, because you got to study that long term. But thanks for that. You just gave me a thought.
There are more questions in the room, but I want to turn to Ed and ask if there are any questions from our virtual audience.
Yes, thank you. One of the questions that came up a few times is, do you ever find challenges in assessing social determinants of health based upon the social stigma that is applied by society to a lot of these, such as, say, homelessness, for example?
I'll start on that. So I think one of the big challenges that is coming up, and it's going to become more and more apparent because of just regulatory requirements, is gathering of SDOH data, both at a person level, through assessments, or when not available, through Z codes and through predictive models. And this was mentioned, everybody lies to their doctors. Everybody has a very warped view of themselves, right? I mean, 90% of people think that they're in the top 10% of financial, income in the world. So I think there is a stigma attached to it, especially when you combine it with cultural norms, right? Nobody wants to go out there and say that I am in need or poor. And even though they may be in need. So I think one of the big things, again, we were working on that at Optum, and I think there should be a lot of work around it, is where does the SDOH data come from? Does it come from the person? Does it come from an assessment? Does it come from Z codes? Does it come from a predictive model? Does it come from an imputed data? Does it come from consumer data? Because each of them have different levels of accuracy and coverage, and become very intelligent about how accurate and complete that data is is really, if we can figure that out, and I mean, CMS is going to require it in 2024 for Medicare Advantage, right? A lot of states already require gathering SUH data. The question is, how do you make sure that people are actually very transparent? And I think trust, again, comes into the issue, right? You have to have that trusted relationship with whoever you're talking to be able to say that.
The only thing I would add is, yes, where the information comes from absolutely plays into the accuracy of, and I wouldn't even say the accuracy of, it's what you don't hear because of stigma associated with it, but also the time at which the question is asked, because when you are in crisis and there is a health matter, a pressing health matter, you're far more inclined to share your information. When you're not in that type of crisis, there's more of a likelihood to either not share or not share as completely, just because of stigma associated with expressing.
Maybe we'd like to just forget that it doesn't exist, right? Right, absolutely. One last question, and then we'll transition.
All right, I'll try and be very brief here. First off, I love the slide with equality and equity. I think that's a great point. It reminds me of when my kids were in hockey, they had people wearing shirts that say, my goal is to deny yours. And you kind of address some of that when you talk about how you picked a very small and very concise exercise, the maternity ward, or you picked different ways. And I'm kind of curious if you could share or expound on what other techniques you might use to get past that cultural resistance of equity where, hey, you shouldn't have that because I only got this.
Who's going to take that?
That's a tough one. I think, again, and I think this goes back to my initial talk, one of the big things that I feel like the focus of everything should be here and is, it's not social determinants of health, it's you determinants of health, right? It's what's making you. What are your barriers? What are your motivators? What are your trust issues? What are your literacy issues? What are all the stuff that prevents somebody from getting the care they need or wanting the care they need, and more importantly, having the best outcomes, right? And that's tough, right? We don't deal in person-level health, actually. We mostly deal with population health, right? We deal with people, because dealing with persons is hard. And I think the more the data can get to that person-level information around social determinants of health and connected in the clinical data, and like some of the work we did at Optum, then saying, how does social determinants of health impact disease progression? Things like that. The closer we will get to that you determinant of health type situation.
So I agree at the micro level or the individual level. I think this is more of that policy and resistance.
Yeah, the policy, yeah.
Transition at this point, Mike, would it help to transition, or do you want to take that?
I'll just very simply say training and intentional strategy. When folks are trained and the expectation is established that we're going to have an intentionality around design that is equitable, that has equity built into it, not just one size fits all, it changes over time. But you have to establish the expectation
so
and be intentional.
That's recommendation for the internal team coming up with the plan or the next product?
There you go.
Or is that training like the
We're going to have to break, though.
Fair
But thank you. And wow, what a panel this has been. Thank you for all of the work that you do for us, because you're our sponsor at UnitedHealthGroup, for all that you've done. Best of wishes to you in everything that you will accomplish. We want to hear about that. And I think you determinants of health, we're going to be hearing more about that, I'm sure. You could just hear it resonate in the room. So thank you very much. Thank you. Slightly different format to yet our next session, which is, and I'm going to do a quick just title introduction of the individual who's going to introduce our next speaker. And then that next speaker will be doing a Zoom chat interview with Pinar Karacha-Mandek, who is anxiously awaiting for us to cue her in a few minutes. So I'm going to introduce Dr. Benjamin Lynch. He is the director of University of Minnesota's Supercomputing Institute. Who even knew that the University of Minnesota had a supercomputing institute? So, Benjamin.
Thank you. So, for reference, yeah, the Minnesota Supercomputing Institute has been here since 1982. So, first university to have a supercomputer in the country. So, okay. It's my pleasure this morning to introduce our next speaker, Dr. Dana Gelb Safran. Dr. Safran serves as president and CEO of the National Quality Forum, NQF, where she oversees healthcare quality measures and expands NQF's portfolio to advance healthcare quality, outcomes, equity, and affordability. Dr. Safran has held key roles in prominent organizations, including Blue Cross Blue Shield of Massachusetts, where she contributed to the value-based payment movement, and Haven, a joint venture focused on innovative healthcare solutions. Before joining NQF, she was an executive at Well Health Incorporated, a healthcare technology company. A faculty member at the Tufts University School of Medicine, Dr. Safran showcases her dedication and expertise as the commissioner of the Medicare Payment Advisory Commission since 2017. Let's all welcome Dr. Safran.
Thank you, everyone. The world of hybrid, I was down there maybe 5-10 minutes ago. Now I'm back in my office. So honored to host you, Dr. Safran. Thank you so much for being here. And so I will start with a little secret that I never shared with you, but as I was launching my own career as a health economist, this is back in 2004, you were this role model for me in the academic path for me. I was one of your friends. And so your career path has always inspired me with all these various leadership positions and executive positions, both in the academia as well as in organizations like the Blue Cross Blue Shield Massachusetts, like Haven. We were all wondering about Haven as it was built, being built as a joint venture of Amazon, Berkshire Hathaway, and JP Morgan Chase, and then your recent role. So I wanted a little bit of a selfish request. Could you tell us a little bit about that career journey? Because I think it's very inspiring. And how did you navigate your current role at the National Quality Forum?
Well, Pinar, thanks for sharing that, and publicly, no less. But it's wonderful to be here, even virtually with you. And thanks for the invitation to share a little bit about my path. So my background and training is in public health and quantitative methods. I knew from the time that I was early on in my career, before I went to grad school, that I was interested in the intersection between decision-making and science. And over the course of my training, I came to really understand that I loved research. I loved getting my hands into data and seeing what story the data could tell. So in my roughly 30 years in the field of quality measurement improvement, you can divide that broadly into two chapters. The first half of it, I was in academia, and I was a measure developer, developing measures of healthcare quality. Most of that time, quality measurement was a rather sleepy academic exercise. And all that changed in 2001 with the Institute of Medicine's reports. Well, 2000 and 2001, with some very important reports from Institute of Medicine, now National Academy of Medicine, that really highlighted for our country that we had a concept of our healthcare as the best in the world. And yet, one report, To Err is Human, telling us that, medical errors were the 8th leading cause of death. And a report shortly thereafter telling us, there are 6 pillars of high quality care, and there's not just a gap, but a chasm between us and good performance on those. And suddenly my academic part of my career came to have a very different flavor, because the measures that we had been developing and validating and publishing suddenly were being hotly demanded for real world use. And ultimately that took me to my role at Blue Cross Blue Shield Massachusetts. So started that second chapter where I went from academia and a measure developer to now a consumer of measures, using measures to try to make care better, more affordable, more equitable. And the role of Blue Cross, I was there for 12 years. And as was said in my introduction, one of the really important parts of my time there was being one of the architects of a payment model called the alternative quality contract that I hope we'll talk a little bit about today. But that model really catalyzed the value-based payment movement. And, my opportunity at Blue Cross was my first paid role, where I was at that intersection of using measures to actually make care better and more affordable. And that was incredibly exciting, formative time for me. I, as was said, went from there to Haven. And that was, a real eagerness on my part to be on the provider or the purchaser side of the table. I was at the time frustrated that purchasers weren't having more of a driving impact to make care better, and wanted to be part of something that would change that. And, sadly, Haven was relatively short-lived, but it was incredibly exciting, important work. And some of the innovations that we had in those 2 years live on. And now here I am leading the National Quality Forum at a very important time. I like to say the role of measurement in US healthcare has never been more important. So it's a great honor to lead this organization at this time.
Thank you so much, Dana. And I think you'll tell us a little bit more about this particular role at the National Quality Forum as well, because I would like to hear your perspectives on, you've been on the academic side of developing these measures, right? And then now the consumer side of using them. I mean, I really resonate with that intersection as an academic as well, because I feel like very often we create these ideas and develop methodologies, but what it really becomes so meaningful and so amazing is when it comes to real life. It's sometimes even nervous, right? You feel nervous when your work becomes used in real life, but that's when it really makes an impact. So thank you so much for sharing that. But so both either from academic or your current role or in the past as a consumer, can you tell a little bit about what it means to measure, what it means to measure quality of care? What are we measuring, and why do we need to measure?
I love that question. And what does it mean to measure quality of care? For that, I would say I take the view that we use that Institute of Medicine framework from the Crossing the Quality Chasm report. I think that is the most enduring and useful framing of what we mean by quality. And that report set out 6 pillars of high quality healthcare: safe, timely, effective, efficient, equitable, and patient-centered. And when you ask me, what does it mean to measure quality? I say it means all 6 of those pillars. So it doesn't ignore equity at the expense of safety. It doesn't ignore affordability or, in their framing, efficiency at the expense of patient-centeredness, all of that. And so then to the part of your question, why measure? It's often been said, we can't improve what we don't measure. And it's also, I think, really, really important for all of us to understand that that some dimensions of care and of health are challenging to measure. But I think, in my experience, there is yet to be a dimension of health or care that we could not measure. And it's, if we want to be able to know where we are and where the disparities are in performance, and then track our progress on improving and understand which kinds of interventions help drive improvement and for whom, we can't do that without measurement. We just simply can't. Otherwise, it's just a feeling, right? Of, you know, does this seem like it's getting better? At the same time, we have to be really careful that the measures are measuring what we're saying they're measuring, right? If I say that we have a measure of patient trust in their physicians, and actually what that measure is picking up is more noise than signal, then we're doing ourselves a disservice thinking we have information. And when we start to use that measure in what I've called in my work high stakes ways, like payment or public reporting or accreditation, or, you know, value-based care networks, center of excellence models, then we're really using measures in a high stakes way, but doing a disservice to the consumer who might be making decisions based on that information, to the provider health plan who might be getting paid or not paid based on their performance. So, you know, the accuracy and integrity of measures is absolutely central to our ability to use them to drive improvement. But without them, we really have no basis for knowing what needs improvement and how we're doing.
It's very interesting, Dana, that you know, in addition to just measuring, because we need to measure to improve, you highlighted some of those high stake areas. Could you tell a little bit more about these high stake purposes, in particular, maybe the measures for payment?
Yes, yeah. So I think I just named them, but what I'll say is that you know, when I first came to my role at Blue Cross Mass, I said, look, there are four main ways that a health plan can use data and measures to try to make care better and more affordable. The first of those is to share performance information with providers in our network with some benchmark, you know, effectively holding up the mirror and saying, here's how you look on this thing relative to others. That's not a high stakes use, but it is one way to start the quality improvement conversation. The next is you attach dollars to the measures, and you know, that's sometimes called pay for performance. In the early years, that's more what it was called. Now it's often called value-based payment, but you're attaching dollars, and we'll come back to that in a moment because it's so important to this conversation, I believe. The third is attaching reputations to measures by publicly reporting the information or by sharing it with other clinicians to inform referrals. That's another form of attaching reputations to performance. And then the final of the cycle is embedding performance measurement into insurance product designs. So attaching market share to performance measures through select networks or tiered networks or center of excellence models. Those three of the four, the attaching payment, attaching reputations, insurance designs, those are high stakes uses of measures. An additional high stakes use of measures that I'll highlight, which was not in my frame when I was thinking what are my levers at Blue Cross Mass, but is very important for completeness, is accreditation, right? So NCQA does accreditation of health plans, the Joint Commission does accreditation of hospitals. That is a high stakes use of measures as well. Would you like me to come back to payment and talk a little bit about that?
Yes, maybe one other question I wanted to ask you, in particular in the context of these high stake measures, and you can highlight the payment if you prefer. I wanted to get a sense of where you see as the state that we have in terms of the collection and measurement, and what are some ways going forward that we can improve, and sort of what are some next generation thinking on these measures?
Yeah, great. Well, so I will talk a little bit about the payment as a lead-in to answering your question about, what do we want to say about the portfolio of measures that we have available today? So in my role at Blue Cross, as we've said, I was one of the architects of a payment model that really catalyzed payment reform in the country. And why it did that was that we had what we called our twin goals of our payment model. And those were to improve quality and outcomes while reducing cost and cost growth. Now, that's kind of the holy grail of quality improvement or healthcare improvement, right? And there were articles from the very first year published by a team at Harvard Medical School that was studying this alternative quality contract while we were implementing it and over 8 years, showing that from the very first year, it was accomplishing those twin goals. I personally believe that payment is the single best lever we have for getting the healthcare system that we want, and that performance measurement, quality measurement is the engine of payment reform, right? And so then the question is, do you have the measures you need to get to the high performance healthcare system, right? To get safe, timely, effective, efficient, equitable, patient-centered care. And I would say to you that today, the measures that we have, and there are over 400 measures in our country's portfolio of NQF endorsed measures, are all important measures. They've been shown to be reliable and valid. They've been shown to be clinically important. However, they are not the measures that we need for getting to the future. And here's why. The majority of those measures grew out of a fee-for-service mindset and a fee-for-service way of paying for care. And the difference between fee-for-service payment and value-based payment, well, there are many differences, but one of the stark differences is in fee-for-service, we are quite literally paying for each transaction, right? You do a thing, you bill for the thing, we pay you for the thing, job done. And the performance measures built around that model are equally transactional. They're very much about care processes. And as you then get to value-based payment, where you're going to have a global population-based budget, accountability for the total cost of care, accountability for the outcomes that you produce, accountability for the patient experience you produce, you're now accountable for the entire spectrum, not just one encounter, one hospital stay, but the whole spectrum of care for a population, from prenatal care to end-of-life care, everything in between. We're going to do that based on process measures. It's an overwhelming amount of measures. And we have heard, and we hear, I would say, more every year, provider distress about the burden of measurement. And some of that burden has to do with the use of technology, which hopefully we'll talk a little bit about in a few minutes, but it also has to do with the number of measures in their contracts. Value-based payment is a way to get to more parsimonious accountability measure sets, because now we're not holding you accountable for the processes you use, but we're holding you accountable for the results you produce. And you decide what process. You went to medical school, your colleagues went to nursing school and social work school and pharmacy school. You know what the right processes are. Let us hold you accountable for the outcomes. But we don't have today in our measure sets the outcome measures that really correspond to the needs we have in value-based payment. And that's some of the work that I'm leading here at NQF that I'm extremely excited about.
We want to find out about those measures as soon as we can. So you mentioned in terms of the 6 pillars, equitable care, equitable, affordable, safe, timely, effective, patient-centered, right? So how about in terms of actually measuring equity in our healthcare system, in our communities? Where are we with that?
Yeah. So, I heard in the last panel the comments about, both how long the speakers' organizations have been at this, but also characterizing, and I think it's fair, that it's relatively new, that this is really on the front burner for the country. Honestly, it reminds me of right after that Crossing the Quality Chasm report was published and patient-centered care was named as one of the pillars. Suddenly every provider system and health plan in the country had patient-centeredness on its mission statement, even though nobody was quite sure what did that mean and how will I measure it and how do I know if I actually am patient-centered. I feel the same has happened now with health equity over the last couple of years. It's on everybody's agendas, on everybody's mission statements, and testimonials about their commitments. But then there's a lot of, what does that actually mean? How would we know if we're providing equitable care? I would say that there's, broadly speaking, two broad ways that we know. One, with our existing measures, so any or all of the 400 some odd measures that I mentioned in the NQF portfolio of endorsed measures, or some of the new outcome-oriented measures we're developing, you stratify those measures by the variables that you're concerned could be sources of inequity, right, disparities. So you stratify them by race, by ethnicity, by rurality, by disability, by gender, by age. And you look to see where the disparities are. That is one important way that we measure health equity. And the other, of course, is we do that and then we summarize that into an index, right, across a group of measures, whether that's the whole population set of measures or whether that's your cardiovascular measures and your mental health measures. You summarize across a set of measures to get a health equity index to see how we're doing. Now, again, for big dot measures, for parsimony, an index is a great thing. By itself, it's not going to be actionable, though. We have to then take it apart to see the stratified information at the measure level to know what are our priorities for improvement. And the final thing I would say, and I heard reference to this in the last session as well, is we lack a lot of the underlying data that we need to actually know where we are with respect to health equity. And what I mean by that is, for many characteristics that we're concerned about with respect to equity, and let's use race as our example, the amount of data that we have about patient self-reported race, which is the gold standard, is very, very thin. Now that's going to change, and it's changing pretty quickly. But how do we measure inequities based on race if we don't have information about race? Well, we've started, several years ago, in fact, more than a decade ago, in some cases, in some of my experiences in Massachusetts and what was expected by the state, doing that using proxy data, right? Using geographic data to geocode and estimate what somebody's race probably is. That may be okay for some purposes, but it's not okay for care. And so more and more we understand that you can't use that, and you shouldn't even use what a clinician or caregiver jots down as what they perceive to be a person's race. You need to ask the person. But today we're really lacking in those data. And then you have to standardize, okay, well, if we're going to ask about race, what are the categories we're asking about, right? So the statement, the devil's in the details. When it comes to measurement, the devil is always in the details. And those are some of the things we're having to work out right now.
No, thank you so much, Dana, for joining us. I am going to defer the Q&A back to our 3M auditorium. Thank you so much for joining us.
Thanks so much, Pinar.
Thank you, Dr. Safran. Thank you. Thank you, Dr. Safran, and thank you, Pinar. Again, we want to stay right on time, so we're going to transition to our next session. And our next speaker is James Burrows, and James is the SVP of Government and Community Relations and the Chief Equity and Inclusion Officer for Children's Minnesota. And I have the privilege of serving as the board chair for Children's, and therefore the opportunity to work with James on a regular basis in the boardroom. What a treat to have him here in a different context where he can share his expertise with you. He has had system-wide impact regarding health equity from the board level to the front lines. We'll ask him a little bit about that in a moment after he makes his prepared comments. And prior to Children's Minnesota, get this, he served in the office of Governor Mark Dayton as the state of Minnesota's first chief inclusion officer, which made him also making history as the first state's chief inclusion officer in the entire United States. And we are fortunate enough to have James here, so thank you.
Thanks, Raquel. Can you all hear me okay? All right, you have heard a lot about health equity, data, and I'm the end of the program. I promise I'm not gonna repeat all the things you've heard. So out of these slides that Raquel made me put together, because at first I told her, Raquel, I don't have any slides. I'm an attorney by training. I like to just talk. I'm a former litigator. I'm like, I can wow the crowd without slides. So James, get some slides. So then I said, okay, I got slides. I got 43 of them. So now, we're not gonna go through all 43. Some will skip fast. I'll send the deck to you. But I wanted to kind of show the tie-in about what my work is in equity and inclusion, community relations and government relations, how we use that data at Children's to affect our tactics and strategies, and how those lead to outcomes and measuring those as well. So that's gonna be the gist of my 15 minutes, and somebody keep me on time, Raquel. Then we're gonna talk some more with your questions and interview questions Raquel may have as well. Does that work for folks? All right. This is a quote I use all the time. Of all the forms of inequality and injustice in healthcare is the most shocking and inhumane. Why? Because a lot of times it affects the people that we serve daily, our kiddos. Our kids and families that are the most vulnerable. Those disparities we talk about on paper are actually people's lives. Those disparities we talk about in homelessness are actually people's lives and their ability to not be able to put a roof over their head, get any income. And a report I'm going to suggest you take a look at is the State Demographer's report in Minnesota around the well-being of all families. She actually breaks it down by racial data and digs deeper than just your surface level. So for example, under Latino, there are lots of different people who are Latino of different ethnicities. She breaks that down, African, African-American. It's important to look at that data because when we talk about health equity solutions, the reason we're inhumane here and shocking because we don't do equity the way we should. We say things like, and you know, it's a mistake sometimes, but it's a lot of times we equate equity and equality as the same thing. And we can have an equal program looking for equal outcomes, but that equity solution is not geared towards who it should be. This is my org chart. You don't care about it. There's lots of people that report to me. The only reason I want you to see this is in order to do this work, it can't be just one person. So if you're at a company and they say, hey, this one person does health equity, and where's their team? And they say they don't have a team, you don't do health equity. All right, pictures of the team, pretty pictures. I like mine, so I put this slide up. I have a very diverse team, experience-wise, racial-wise as well. I won't go through all their positions, but they work collectively with the partners at the bottom there in community health, which I'll talk about, in talent acquisition, we talk about hiring. Our health equity team does not sit underneath me. It sits under our quality improvement area, but we work closely on a regular basis regarding our health equity outcomes, which I'll talk about a little bit later as well. Our framework is based upon data. We start with our values at Children's, and we also look at our performance metrics, our leader competencies. We also do self and team assessments. One thing I'm going to talk about is called the Intercultural Developmental Inventory. How many of you have heard of the IDI before? So it's a tool that we use not only with our staff, but with our board as well, to assess where we are from a cultural lens standpoint, and then develop tactics and strategies, accountabilities and measurements around that. The IDI is not gold. You're not going to take the IDI and be like, man, okay, we got it now. If you take the IDI, somebody uses it, and you do nothing afterwards, you've wasted about 45 minutes of your time. But if you use it as a tool to assess where you are in the organization, it'd be a great tool in developing health equity, measurements, metrics, outcomes, and strategies. We also talk about the collective community health in a second, what that is. We have learning and development goals and outcomes as well, and it all ties back to what we call IDEAs, inclusion, diversity, equity, access, and solutions. You don't have to use my definitions. That's why I'm not going to go through them. I like them. They're mine. But you make sure you have some definitions, because the thing I hate most is when people say this to their company, man, we got a DEI department, diversity, equity, inclusion, and we have a health equity department. I don't really know the difference, James. What's the difference between the two of them? There is a difference, but there is a synergy and an interconnectedness as well. But unless you have definitions written down for people to work and operationalize, that won't work for you. Vision and mission, this is tied to our vision of being every family's essential partner and raising healthier children at Children's. The thing I say most about this is we don't do diversity and equity, inclusion, and health equity on the side. We don't have a separate plan for those things. They're built into our strategic plan that our board holds us accountable for. And that's important because if you have it on the side, it gets treated on the side. When budget cuts happen, when things get tight, when priorities start to happen, you start to do what? Look at things you can put on the side even further. If it's in your strategic plan, you got to do it. You just have to be more efficient and effective around it. This is what success looks like. I'm not going to go through this. I'll talk a little bit about it later. It's my other team. I like these pictures too. The Collective for Community Health. We started 2 years ago realizing that unless we address the social determinants of health in a direct way, we wouldn't be able to sustain our patients and families in a healthy situation going forward. Because as you know, 80% of what affects patients' health happens outside of the four walls of a hospital. That being the case, we said, okay, what can we do? I think somebody mentioned earlier about housing and homelessness, food insecurity. A lot of our families are going through legal troubles and things like that. So we developed a system where all of those things, once we assess the family and they come in, we help them address. So we partner with other organizations in the collective to address those things as well. And in addition to that, we partner with community organizations about bringing health equity to the community. It's an organization called, I think, Live Healthy Lives in North Minneapolis. They did an event for the first time last year, bringing people in the community to talk about health, wellness, food insecurity, food deserts in their particular neighborhood. So we find ways to operationalize that. Somebody mentioned earlier in the presentation about how do you get, I think it was a pediatrician over here, families to understand the importance of these things. What we realize is we're treating the kiddo, but we're talking to the family. And if we connect with the family in their community and what they do through the Collective for Community Health and the work that we do, it makes it a lot easier for those kids to understand what health equity is and limit some of those disparities as they become into adulthood. It's not perfect, but that's what we're working on. As part of this work, too, is advocacy. And I'm going to talk a little bit about that. Government relations, advocacy, our lobbyists report up through me. Why is that important for health equity? Well, unless you have some policy changes to the system, we can do as many programs as we want, or many partnerships as we want. You have to have that system change at a higher level. One of those things that happened this year, and we were on the forefront of testifying in favor of it, was free lunches and free breakfast for kids. Once again, food insecurity, free lunch, free breakfast, we're at the forefront of that. That's going to help health-wise. In addition, thank you. The Crown Act. Now see, they're clapping. I could have taken up my time, sorry. So, the other piece of it is the Crown Act. The Crown Act is a great piece of legislation. It hasn't been passed in all 50 states yet, but it will be, protecting folks who want to wear their hair and bring their full self to a place, school, work. You shouldn't be told that you can't come somewhere because your hair is a certain way. Now, are there discrimination laws against that? Obviously, but some of those weren't working enough. So the Crown Act has been passed here in Minnesota. We were at the forefront of testifying on that as well. Why are those things important? That advocacy leads to changes in the health system, it leads to changes in the health community, there's those partnerships. So those things tie together for us. Cute pictures of people and families, I love those, so I always put them in there. Why are we doing this? The data we looked at was our patient population has changed. Next year will be 100 years Children's Minnesota has been in existence. Over those 100 years, our demographic has changed. This number right here has changed even more because this number now is about 45 to 47% patients of color, as opposed to what it was, this was only about a year ago. Why is that important? Because you have to have culturally responsive, culturally humility care as well. It doesn't mean that the docs you have now have to go anywhere, but they have to understand when you're talking about well-controlled asthma in, let's say, the Somali community, or you're talking about mental health in the Nigerian community. it may be perceived differently, and the remedies that you give and the traditional things you've been taught may not work as well in those communities unless you have a cultural understanding. So we're making sure that equity is tied to that, training, education as well. Also, too, for innovation and business development, I invited two of my colleagues here, Brad and Eve. I think I saw both of you. Yep, cool. So Brad, he's the guru of innovation at Children's, Eve, the guru of business development. I said to them, man, if we get this equity, inclusion, and health equity thing right, can this help our business? They're like, yeah, of course they can. Here's some strategies around that. So I'm not the diversity guy. I'm the guy who understands equity, inclusion, and how it can be a business asset. So that's important as well. When you talk about health equity, it's going to help communities, it's going to help families, it's going to help what you do, but it's also a business asset, and you weave it into those business development things as well. Real quick, Arkel, how much time? 3 more minutes. Skip that slide. Social determinants of health, I'll talk about that. You know, 80% deals with stuff outside. Oh, this is the last piece on this. Racial disparities come from what? Racism. Okay. Simple, just think about that. So don't avoid topics of talking about systemic racism, institutional racism, sometimes individual racism, but that's less important. But you gotta address that as a system before you can start talking about the disparities. We at Children's are getting better at discussing the system piece and how we address the system so we can change the disparities, because those tactics have to be tied to eliminating racism and behaviors around that. That's our definition of structural institutional racism. You don't have to use that one, just have one. I think Mike did something similar to this, but I like my pictures with the fence and stuff. But equity is about private access on the end and social justice. The reality is lots of people have more boxes than others, more access than others in healthcare. We got to get to the end of social justice. And then talked about that, talked about the Crown Act. Gender affirming care. Today, my colleague, Dr. Angela Geffert, will go over to the Capitol where the governor will sign a prohibiting conversion therapy in this state and also a trans refuge bill. We have a gender affirming care program at Children's, but we also have advocacy around great policies for kids or LGBTQ and need to be protected. Those things sometimes don't go hand in hand with health equity, but how you show up in community and how you show up in the advocacy front is what people are looking at as well. It's not just the service you provide when you're there, it's about where you're going to show up and use your voice as well. And we've been doing that today. I want to stop here. The work starts with leaders. It has to be at the top. And Arkel is going to come and ask me some questions that I may know answer to, I may not. Thank you very much.
James, let's pull that chair around. So
I'll pull it around. Okay.
That'll be awesome.
All right.
Okay. How fun to be able to interview James.
And I can talk about board stuff when you ask me to.
I know. Okay. Awesome. So, first of all, again, thank you for all that you do for us, for the state, for the children in our state, and you're leading the way for children in the country. So we really appreciate that. But you didn't follow one of my instructions as your board chair, which was I wanted you to show that dashboard. Do you have that slide up there?
I do.
Could we bring those slides up again? Do you know where it is?
I do. I was waiting for your question so I could bring it up.
Okay, let's do that. So as you're bringing that up, James, James and his team and Children's do so many extraordinary things, but one of the reasons I thought it was so important for James to be here was to show that in addition to all of the things that he talked about, equity is measured at Children's, and there is a dashboard that is part of the board packet, it's part of the quality committee, and it's part of what the entire organization is accountable to. And so unless you measure it, you don't improve it. And I'm wondering if you could just touch on that a little bit and talk about how you have designed this dashboard.
Sure. So I take no credit. I did not design it at all. It was designed before I got there, but I do use it on a regular basis. I'll talk about this dashboard and also others. When we talk about health disparities, what we found at Children's there were 3 we wanted to focus on first, because those were the most ones we had ready access to the data, and also 2 ones we had ready access to some tactics. One was well-controlled asthma. We found the largest disparity between our black children and our white children. We also found the largest disparity in combo vaccines, getting the vaccines right before school and early age in our black and white population. We disaggregated the data and we looked at other populations of color, Latino, Asian as well, but there wasn't as great a disparity, so we started there. That's an important piece to begin with, because a lot of people will say, well, people of color disparity in your white population. How you have strategies for those different ethnic and cultural groups will be different, so please disaggregate that data to that level as well. And sometimes you can't just do black. If it's East African, West African, and African American, it's going to be different for those groups too. But this is very simple. This is a high level view, and I'll show you the more detailed one. We look at the disparity, we look at the disparity difference there, and then we make sure that we measure this every month, send it to our board, and talk about the strategies we use, which we use on this chart to control those disparities. So if you look at the left-hand corner here, in 2020, that disparity rate was average about 14%. Now it's down to 4.6% because of the intentional strategy we did within the clinic, within the hospital, but we measure it on a monthly basis, get it to the board, and they hold us accountable at the quality committee level, but also at the board level as well. The other piece I'll say about this, it's done for combo vaccines and also our experience listening, which is basically our survey of our patients and families, but it's also done too in other ways at the hospital. So our strategic plan, and this question is good because I'm other measurements. We also measure our hiring. So we also measure how many people in our diverse workforce. We want to have a workforce that reflects the diversity of our patients and families. Our goal is to, by 2024, have a workforce that's 34% people of color. When I started in 2019, that number was 19%. Our goal this year is to get it to 26.5%. As you can see here, each month, we have a number here about what the actual diversity is. And right now it's at 25.03, not including April. We look at that for also our executive leaders as well in that middle chart there. It's at 16.6% and the goal is 16. And we also look at attrition rate for our employees of color and also our majority employees. Why is that important? What gets measured gets done. And those are the things that we do at Children's. And sometimes we fall short. Last year we fell short because we had an overly aggressive, because of me, diversity goal that we didn't hit. But we said, okay, what do we do differently this year? So we're averaging, if you look to the far side over there, 43% people of color hired in January, 40% in February, and then 37% in March. People would say you can't do this, because this is Minnesota. We don't have that. We can't find anybody. You can if you stretch your imagination to find people in different places. We didn't change any of our standards. We didn't say we're going to find somebody who doesn't meet employment standards. We said we're going to find somebody who can do the job in our hospital system. So we do the same thing for, real quick, supplier diversity. We're going to spend more money with businesses of color in the future. We had to measure where we were. This number reflects 0.1% of our spend is with veterans, racial diversity, and women-owned businesses. We're going to do better this year. Our goal is to increase that by 6%. So, answer your question, those are the measurement tools we use.
Thank you, and thank you for expanding it even beyond quality, because it is integrated into all different parts of the operating infrastructure. So, when you came in 2019, you probably had a little bit of an uphill battle because this is not mainstream. What was your greatest barrier in getting to this point, if I may ask?
My CEO, no, I'm just joking. Mark and I have a good relationship. It wasn't this, it was my CEO, and I'll be honest with you, because Mark had a vision for equity and inclusion. Dr. Mark Gorlick, our CEO of Children's, he talks about it all the time. He had talked about systemic racism, white supremacy, and other things since 2016. But nobody else in the organization knew what all that stuff was. So it's kind of like, okay, now you got a chief equity guy. Our CEO said all this stuff. What does that stuff mean? And how does it relate to me taking care of kids? So the gap had to be, I had to say, okay, hey, Mark, that's great, but how do we educate folks to get them up to the speed of where you are? How do we make sure that the board understands, as they evaluate this work, they understand it as well? So I can't say that he was a barrier, but I had to bring the organization and our CEO was out further together to understand this is how we move together slowly. as opposed to getting out here quickly. So that was the main thing. And just getting, also myself, getting familiar with the healthcare field. I'm not a healthcare person, lawyer by training, not a politician, but been in politics for a while. Knew nothing about healthcare, but it helped me understand getting that knowledge, bringing that together with equity and inclusion, helped us move forward.
And I think at a high level, right, it's leadership that brings that together, and it's never easy. Sorry about that. It's never easy, but it takes leadership that brings that all together. But one of the tools that you've used, and you referenced it earlier, was the IDI, and maybe you could say two more things about it, but then we can talk a little bit about the board's experience, my experience in doing this.
Sure, just quickly, it's a tool that's used to cross-culturally validate, measure intercultural competence. There are other tools out there. It's not the only tool. There are others as well. It's one that I'm comfortable using because it's simple. People understand it. And the part I'm going to warn you about, you can have the IDI assessment, but you have to have excellent coaches to work with one-on-one the people who take it to understand where they are and develop a individual development plan for them to work on things of themselves. Why is that important? Because that then helps them have that equity discussion that the board is having, helps the board understand and evaluate programs from an equity lens. If you have domains of quality and equitable care as a part of that, you got to be able to discuss equity around that. This helps them do that, but you got to have those coaches. The other piece of it is on that continuum, it helps to see how we grow and how the board has grown. So our foundation board and our governance board all have taken the IDI, they all have had the coaching experience, and in the work that they do, bringing equity, they have their own discussions around that and how we move that work forward. And I'll say this too, it was not tough, but it was like, I won't say the word requirement. It's expected. If you join the children's board, you take the IDI, you participate in this work. If you don't want to meet that expectation, it's expected. You can go find another children's hospital to do it with. So that's not a requirement. But it's kind of like saying, I don't care about kids, I want to join your board. Or I don't care about these kids, I want to join your board. We've said it's not a painful thing. It's not holding you in a way that we're going to discount who you are or reprimand you. It's going to help us as a system move forward. And all of our board members have been receptive to that.
Oh my goodness, and it's really been awesome. I would say that I haven't personally experienced any board member who hasn't reacted to this in a positive way. And if there is somebody, then when it comes time to renew their board service, it's just not a fit, right? So I would call it less of a requirement and say it's just less of a fit.
Yeah. I love my Minnesota friends. Less of a fit. I like that.
I have a New Yorker side, but I'm not going to let that out right now. Okay.
You adopt it.
You travel to many other hospitals, sometimes to help, sometimes to consult, to share with them how you've put this in place at Children's. What's their reaction?
For the most part, I'll start with those that are outside of Minnesota. So I'm on the advisory board for Children's Nemours, which is in Delaware and Orlando. Great reaction. They've asked me to come in, talk to them about how we implemented it, what the leadership did, how they can do that for patient care and their families. So great reaction, and they want to do more. They're actually coming out for a conference in May, and they're going to visit us for a whole day to kind of mirror what we've done. Other hospital systems, they're receptive, and they want to do stuff, but this is what I asked them. I asked them, okay, so how large is your system? And typically it's much larger than our 5,000 employees. And then I asked them how many people do they have in equity, inclusion, or health equity. And that chart I showed you earlier about all those people is like one person, and then it's 3 people over in clinical areas, and it's 2 people over here, and it's part of that person's job, a 0.3 of that job, and that person's a 0.12. I was like, okay, so how do you get anything done? And they don't. So, and I'm like, well, how do you work with the strategy innovation team? We don't do that. So I think I get a lot of that, and it's not that people don't want to do it, but I keep telling you got to invest, you got to put it in the budget, and if you don't spend money on it, you'll get what you get, and that's unfortunate for our patients and our families and our community.
Right. Let's open it up to your questions for James. You got it.
Great, thank you. That was fantastic. How do you, so you've done an amazing job at making sure that you're hiring a more diverse workforce, but how are you ensuring that you're creating a culture of inclusion and a sense of belonging within children's?
Good question. We have started at the leadership level again. We have equity training, education around inclusive leadership. So each of our leaders, our top 30 leaders, have to take 4 hours of that, and we do equity leadership education. In addition to that, we have cohort groups of those 30 and 5-6 member cohort groups, and they have their own equity coach by which they meet with each quarter, and they can meet with more individually to tell them show them how to make equity-based decisions. What questions do you ask? Those kind of things. In addition, we are a hospital system built on learning and implementing continuous improvement. We build equity in the continuous improvement model as root cause problem solving around that as well. And that's cascading down now to our management level and our other levels as well. In addition, our ERG groups, our employee resource groups, have helped our entry-level employees and more around that level understand those cultural dynamics and create an environment of cultural understanding, well-being, and welcoming. We're not there yet. I didn't show it to you, but our attrition rate for our employees of color is still too high. And it's because people come into an environment and they don't feel like they're welcome, they're valued, or their voice can be heard. We got to do a better job of that. And we also use our employee engagement assessment. We're getting better there at assessing where our employees are, disaggregating that data to see what we can do differently. Does that answer your question?
Yes.
Okay.
Other questions? Ed, are there any questions online?
Yes, there is one. So speaking from the point of view of advocacy for improving health, what forms of data and what forms of presenting that data do you find to be the most useful in convincing stakeholders to engage with certain processes or to take a certain position that would be beneficial?
Yep. I'd say the example I use is the bill that was passed about free lunches and free breakfast. The impact that lack of food security has on the health and wellness, the mental health and wellness, the physical health of children. There's a plethora of data on that. We use that data to say, if we could improve in this area, this would help with health outcomes of children, less trips to the emergency room, less trips to doctor visits, more of a stable foundation. We're getting better health for those children and families as well. We also looked at data around food deserts in particular areas, and health outcomes in those areas were much more negative when they didn't have a grocery store or access to fruits and vegetables, or had a plethora of fast food restaurants and other things that only were the choices there. So we used that data to look at our advocacy piece about, would this be something we should support? We did, and it got passed. Not just because we supported it, but we looked at that's why children should support it as well.
Any other online questions, Ed? No. Any other questions in the room?
I thought I asked my question already, so I was waiting, but thank you so much for the presentation. I've heard you so many times, during children's meeting, and I feel honored to actually see you in person today, James, so thank you. My question is actually follow up on the last question that was asked about the training. Do you feel, I hope I frame my question correctly, the training should include some inclusion for the diverse work group too, like some training for the group that is coming in, which is diverse. Like, do they need to understand some of the cultural aspects of the white population, which is predominantly working right now? Like, is there a middle ground where we are like, okay, let's both meet here, I want to understand you, and then I want you to understand me too, so.
Very good question. I said the answer is yes. So what I forgot to mention was, so our new employee orientation is a day and a half. The first day is 8 hours of traditional forms, fill out I-9s. The second 4-hour day is our equity inclusion. So every employee, no matter what race or ethnicity, comes in and gets equity inclusion education around diversity, inclusion, what it means, that kind of thing. And that's white, Latino, Black, Asian, Indian. The other piece of that is, I used to do diversity training, and I was good at it. I did that's diversity training. People would clap at the end, they get a 5 rating, and nobody would understand stuff after they left. They go put their book on a shelf and like, okay, that's great. In addition to what you talked about, having it for both populations, what I've encouraged our leaders to do, and they've done it, and then we just had a homework assignment recently, to get to know people from different cultures or ethnicities in the workplace and outside of it, and have social relationships. So, my Jenny Soderholm, who's our Chief Development Officer and our President of our foundation, she now has so many, probably in trouble for this, but she has so many Black Girl Magic friends now. It's a lot of fun. Because she has adopted the fact, she said, James, I'm meeting people I never would have met before. I'm forcing myself out of my comfort zone. And I'm learning just by having people who I can learn from and see their different perspective. So I'm doing more of that than training itself. It's more so, how do you get people to meet each other? Mark, our CEO, has dinners at his home with different people with different backgrounds, ethnicities. Our other leaders have cross-pollinated different departments. So their homework assignment was, you talk to another leader, identify some employees of color or LGBTQ employees that you're going to go out and meet and do, and talk to, have lunch with, have dinner with. So we've done more of that because, to your point, you have to have both on both sides. But I want to build more relationships so it can happen more organically sometimes too.
James, are you willing to share what dinner you proposed that I have at my house? It's perfectly fine. I love to cook.
We can share. But, not all the time does our Jewish community, our Black community understand each other.
Our family's Jewish.
Yes, we have a perception about, and I grew up with a perception about Jews, and some Jews could have grown up with a perception about Blacks. So I said, let's get together, let's have a dinner. We're still working on the calendar.
We are.
Because it's important to have those honest conversations about assumptions and biases, and then you get to know each other and you can move it forward. Now, people who are going to be anti-Semitic or racist and all that ain't going to change them at all. I can't reach them no matter what magic class I have. But people who don't understand each other, I can do that, and we can do that by getting together, talking, and building a relationship. And it's helped tremendously at Children's, and I look forward to that dinner as well, too.
Great, and I'll do my best to make it delicious.
Okay, cool.
All right. James, thank you so much.
You.
Really, really appreciate it. Thank you. What a morning. What a morning. I hope that you enjoyed it as much as I did, that you learned as much as I did. And what I find valuable when I go to conferences is to have someone, usually the moderator, tie it together a little bit. And so I'll try to do that for you. Please forgive me if I missed anything that you thought was important, but I'm trying to do all of this at once. But I took highlights and tried to create maybe a little bit of a story so that you have a take-home message and some learnings from the time that you've invested from this morning. So some key takeaways. First of all, from Peter, we must be connected. Of course, that's the entire theme of this session. And we must be connected so that we can give patients their life, not just a life, back. And we can't let fear get in the way of that. From Anand Shah, in order to do that, we need the data. And health systems and insurers and community partners must commit to finding ways to share their data so that we can advance in that cause. From David Ingham, you need to use that data and translate it into information. And I felt so incredibly hopeful with David's comments when he gave some specific examples of how technology is going to make life easier for clinicians and ultimately for patients through optical character recognition, natural language processing, and AI engines that offer things like computer-aided detection, autonomous monitoring, et cetera. Then Mike Currie said that as we use these tools in healthcare systems, we need to remember the difference between health equity, inequity, and disparities. And we need to always remember that equity is not equal to equality. With Ali ultimately saying that we need to continue to collect more data. We don't have enough of that data now, and we need to connect with each other to turn it into something that's meaningful. And that's going to be hard because the right data is personal. It's to the individual. It's not about what we're calling the social determinants of health that are federally defined and in all of the textbooks and papers that we can find, but they are your determinants of health. And it was exciting to hear their very real examples of addressing disparities that drive health equity, because sometimes it's what we're working on in the future, but we heard examples of how they've worked on it and really had some wonderful accomplishments. And it's hard, but it's possible if you focus. And again, we heard Peter say that we can't let the issue of hard get in our way. Dana talked at the policy level and things that they're doing at the policy level to drive all of this forward. The government cannot dictate individual elements of health, but government and policymakers can and should develop and use high-stakes measures. I loved that term, and I loved how she framed how we use those measures. It's not to dictate individual health, but those measures, you have to have those measures. You need to attach dollars to those measures, link them to reputation. I love that because we've usually called that transparency, but transparency is about linking to reputation, and then link performance to product design. And then finally, James, you just brought it home with the high-level work that you highlighted around advocacy and the importance of that, and then really showed us all how the devil is in the details. No team, no health equity, and if you don't measure it, you don't improve it. And you have, in your organization, committed to doing all of that to improve the care of the children in your institution. So I hope that for all of you, that has fueled some ideas about how you can connect with others within your organizations, with other organizations, to bring more connectedness to health in the space in which you operate to make this a more connected world. So thank you so very much. I'm going to hand it back over to Pinar to close up.
What a wonderful, wonderful conference. And can we get another round of applause for Arkel, please? Thank you so much again for being here. I thank all the speakers we've had. I thank our moderators, Arkel, Ed. I thank our BACH team, Rebecca, Becky, Nida, Kim, June, Kalyan, and our other student volunteers. This would not be possible without them. Fantastic IT. Thank you so much for this wonderful hybrid experience we had. I would like to thank our sponsors, United Health Foundation and the university's OVPR Research Computing. Again, none of this would be possible without them. I would like to depart by saying this: we have these kinds of events all the time through BACH, and our next event will be sometime early fall, maybe late September, early October, Health Sector Leaders Consortium, where we highlight what is in the mind of leaders in the healthcare industry. Again, taking this very interdisciplinary, very different multi-stakeholder perspective. So please reach out to your organizations if you want to be part of that in terms of contributing speakers, topics, sponsorships. And again, we will see you hopefully at Convene conference next spring. And I thank all of you to be here, that you're here today, and our virtual audience as well. And it's time to eat. Thank you.